go to the disease of the oral tissues and salivary glands. So when you talk about the oral tissue, you are only talking about the tissues of the mouth. So when you talk of, for example, you say oral exam, you are examining the mouth, the tongue, the teeth, everything within the mouth. So when you talk of oral tissue, you're talking of tissues within the mouth. Yeah. So, and the salivary glands, of course. So systemic diseases, particularly dermatological conditions, exhibit oral manifestation, e.g. like planus, syphilis. So you can look at them, you can Google those ones. So we are saying basically systemic diseases, that is diseases that affect the whole body, can show up in the skin. So one of the things when you're examining any patient, you need to look at their skin, because sometimes the skin will be able to tell us what is going on inside the body. That is the what we call dermatological condition exhibiting, that is, it can appear in the mouth. So some skin diseases, dermatology refers to skin. So some skin diseases can actually affect the mouth also. For example, lichen planus, syphilis. So part of syphilis, systemic disease like syphilis can show us part of it is, can manifest in the skin or in the mucosa of the oral cavity, that is of the mouth. All oral tissue, that is all the tissues that are within the mouth and its environs, may be subject to acute or chronic inflammatory states. I remember in pathology 1, we talked about inflammation, acute and chronic. So you can always refer to those ones to help you know the characteristics of acute and chronic inflammation. Yeah, so oral tissues may be subject to acute or chronic inflammatory states. The most common being dental caries. Dental caries is what we call the tooth decay. That is maybe your teeth developing cavities and so on. Those are called dental caries, and it's sequela. So the results of teeth developing cavities and so on. Of course, you have what we call pulpitis, that is inflammation within the pulp cavity of the tooth, and you will feel a lot of pain. So basically, when we come with tooth pain, they have what we call pulpitis. Yeah. Then we have periapical abscess formation, that is within the tooth. At the apex of the tooth, we have what we call periapical abscess formation and periodontal diseases. When you talk of periodontal, that is basically the inflammation of the gums. Yeah, the gums becoming. That is why you have sometimes some people who, when they brush, they bleed. It's because of inflammation of their gums, for one reason or the other. So inflammation of the salivary glands, we call that chronic sialadenitis. Sialadenitis is inflammation of the salivary glands. And most of the time it's because of obstruction by a calculus, that is a sialolith. Calculus is like stone. So stones also can form within the salivary glands, and it can block. So when it's blocked, you end up with inflammation. Yeah, so you can have also, remember we have talked about acini as part of the diagram for the anatomy of the salivary gland. So they can atrophy. That is, mostly it can happen in any gland, especially you have the submandibular gland. We are continuing with the disease of the oral tissues, the salivary gland. Many benign and malignant tumors may arise in the oral tissue. So any tissue within the mouth can develop a benign or malignant tumors within the mouth. The most common one being squamous cell carcinoma of the lips. So remember, the lip has that part of the skin that is made of stratified squamous epithelium. So it can develop squamous cell carcinoma of the lips, of oral mucosa, or even the tongue. Yeah, and then our wide range of salivary tumors, both benign. So you have also tumors within the salivary glands, which can be either benign or malignant. Yeah, it can arise in the major or minor salivary glands. Then we have the squamous cell carcinoma of the mouth. So somebody just developed an ulcer within the mouth that is not healing. So it's taking time to heal. You treat it, you try managing it, it's not healing. And then, of course, for pathology, if you have to look under the microscope, of course, this one, if you excise it and repair it, and then stain it and maybe look under the microscope, then you are likely to see nests of epithelial cells with the eosinophilic cytoplasm. When you talk of eosinophilic, remember the main eosin and that main that we use a lot, the stain that we use mainly, We have eosinophilic will appear pink stained, as opposed to basophilic mostly that will appear blue stained. So in this case, we will have those nests. Nests is basically cells coming together in a group-like situation, and then they appear pink. That is eosinophilic cytoplasm. Then we have intercellular breaches. That is between the cells, intercellular. Then we have what we call squamous pulse. I think I told you about last time, which appear like just a circular, keratins coming together. That's what they call squamous pulse. Then we have keratinization. So in that place, you can have actually keratin forming within the tissues. So that will make you think about squamous cell carcinoma. And then, of course, sialadenitis, inflammation of the salivary glands. So in this way, present with pain and swelling. Yeah, especially after food, if there is a calculus. So if there is a stone, obviously when you take food, the reaction of the salivary glands will be to contract to release the saliva into the mouth. So if it is blocked, then of course that saliva that is supposed to come out will be blocked somewhere. And so there will be swelling and then there will be pain. And this one mostly affects the submandibular gland. So if you are to look under the microscope, if you are to take a sample or a biopsy of the salivary gland and look under the microscope, you will see chronic inflammatory infiltrate, of which I encourage you again to go back and look at the inflammation that we talked about. So there will be chronic cell infiltrate, so lymphocytes and other cells. There will be a lot of those cells there. There will be fibrosis, and there will be atrophy of the gland tissue. So the gland tissue will appear atrophy that is smaller than normal size. And this may also be caused by viral infection. So this inflammation may just be caused by viral infections. Most commonly, the mumps. Yeah, there's a virus that causes mumps. It can also be caused by bacterial infection, more so Staphylococcus, that is Staphylococcus aureus, and Streptococcus viridans. I believe when you go to microbiology or you've already done it, you know about this bacteria, Staphylococcus aureus and Streptococcus viridans. It can also be caused, this inflammation can be caused by autoimmune disease. Talking about one of them, we call it Gland syndrome. So it's an autoimmune disease, basically that results in salivary gland hypofunction. That means that salivary gland basically is not producing. So the salivary gland, so the antibodies that are formed that destroys the salivary gland. And so the salivary gland end up producing very little saliva. So we talk of it as salivary gland hypofunction. Yeah, so it basically destroys most exocrine glands. So it doesn't just affect this Gland syndrome. I'm sure you can check, you can Google and know more about it if you're interested. It basically can affect any tissues. Yeah, and exocrine glands especially. So glands that produce enzymes that are used, especially that goes into the mouth, the GI system, like for example, the salivary glands, and even among other glands that are exocrine glands. And of course, it can be affected by sarcoidosis. So you can imagine Gland syndrome is likely to result in a dry mouth, dry eyes, dry skin, because there is no enough production of whatever was supposed to be produced, like the saliva. So a dry mouth due to dehydration. So sometimes you have a dry mouth due to dehydration or various drugs, Gland syndrome. This also predisposes to bacterial sialadenitis and leukoplakia. So if you have a dry mouth, it predisposes you to get infection of those glands. So dry mouth, various drugs. There are some drugs that causes somebody to have a dry mouth. Like for example, cetirizine, those drugs that help essentially deal with allergy. Sometimes they causes you to have dry mouth. And of course, Gland syndrome. Of course, you can imagine Gland is probably somebody who discovered it, who first described it, and so it was named after him or her. This predisposes to bacterial infection, and also, of course, calculi. If there is a stone blocking the duct of the salivary gland, there will be status of that saliva, and that saliva is likely to become infected, and so you end up with inflammation of that gland. Then we have pleomorphic adenoma. So in this case, you will have a painless swelling, mainly of the parotid. So you will find somebody, you will examine them, and you see the parotid gland, and you know where they are located. mostly below and in front, anterior to the ear. So you will find somebody with a swollen parotid gland. So around that place, there will be a swelling. So, and it will be painless. That is, if you palpate, they are not feeling any tenderness and they are not complaining of pain. They're just saying there is a swelling. So mostly this adenoma affects the parotid gland. So if you are to look at it under the microscope, and there'll be mixed epithelial and connective tissue components. So we know what is an epithelium, we know what is a connective tissue. So when you look at it under the microscope, that is microscopically. Remember, in pathology, most of the things we look at things as either something is, you can see something under the naked eye, we call it grossly. You can look at it grossly or macroscopically. So microscopically is now histology. You're looking under the microscope. So you're likely to see mixed epithelial and connective tissue components. So it's one of the most common tumors of the gland, of that gland. So usually encapsulated but irregular in shape. Basically, encapsulated means there's a capsule, there's a covering, a definite covering around it. So encapsulated but irregular in shape. So it will not be regular in shape, but there's a capsule, there's something, a covering. So that the way you will think of it like an orange, where there is the covering, there is the orange peel. So something that is covering. So that's what we talk about, encapsulated. Almost all of them are benign. And if you were to go back to the differences between benign and malignant, I know there was a table with you. So go back and look at it, the differences between benign and malignant. One of the thing about benign is that you usually have a capsule. So there's a proper covering around it. Then monomorphic adenoma. So it's a painless swelling. And so this one will mostly be found in male smokers, that is male who smoke. Yeah, and also mainly this one affects the parotid gland also. Yeah, so if you are to look under the microscope, that is, if you are to take a biopsy of that mass and prepare it and look under the microscope, you will be able to see epithelial cells that are forming nests, trabecula, and even forming glands. So this one will help you to know that this could be monomorphic adenoma. Then there's what we call Warthin's tumor. So this, we are still looking at the tumors that are affecting the salivary glands. So it's a painless swelling, maybe cystic. So cystic, mainly it will mean there will be fluid accumulating within it. So the amount that is filled with fluid, call it cystic. Yeah, and almost exclusively. So this one exclusively mostly affect also the parotid. So if you are to look under the microscope, you will see the glandular element consisting of tall columnar cells with lymphoid tissue, including reactive germinal centers. So mostly this one tends to be common in middle-aged and older men, and mostly in smokers. So the typical patient will be a middle-aged or even older man. And if you ask about the history, family social history, they'll tell you they smoke. So one of the things you need to ask is a history of smoking. Do you smoke? Do you take alcohol? Such things. So you see the importance of looking at the history, including past medical history, family social history. That is, when you talk about social history, is use of, for example, alcohol, drugs, smoking, such things. You're looking at drug of abuse in their family and social history. So if you are to take that history, probably tell you is a smoker. Mucoepidermoid carcinoma. It's a long word, mouthful, so to speak. But you talk of muco, you're thinking of mucus. Epidermoid, you're talking of something that is like skin-like. Carcinoma, and there's a carcinoma. And we talked last time that carcinoma, basically, we know they are malignant tumors or cancers that originate from the epithelial tissue from the gland. So this will be painless swelling, and usually it will affect the parotid or can affect those other smaller salivary glands. So, so if you're to look under the microscope, that is, you prepare the tissue and stain it and whatever it is that you need to do, then look under the microscope. So this microscopic, this is what we will see. Of course, grossly or macroscopically, you are likely to see the parotid is swollen or there is a mass around where the parotid would be. Then microscopically, if you are to go and prepare and look at it, Then you will see a mixture of squamous. Squamous basically will be flat cell and glandular forming glands, mucus producing. That is why you come with the one mucoepidermoid carcinoma. So it has mucus producing components. It's the most common malignant tumor of the salivary gland, this mucoepidermoid carcinoma. It comprises of approximately 15% of all salivary gland tumors. Yeah, so it approximately, well, thankfully, generally for the salivary glands, still malignant carcinomas or cancers that are malignant will still be rare. It may be low, intermediate, or high grade. Yeah, so there is something called grading of any tumor or any cancer in the body. So you talk of it being low grade, intermediate, or high grade, depending on the differentiation. So mostly high grade carcinomas will tend to be undifferentiated. When you talk of something being differentiated, so something can be poorly differentiated, maybe well differentiated. So basically, they look like the cells of the tissue that we would expect. Yeah, so they can be low, intermediate, or high grade. So adenoid cystic carcinoma. So as you can say, adenoid cystic, so cystic fluid fills some structure or lesion. So initially it will be painless, but later you have nerve pain. So initially it starts as painless swelling, but later you can develop nerve pain. So looking under the microscope, you will see it mainly consists of epithelial cells arranged in cribriform. Cribriform means sieve-like. You can think of a sieve, the one we use, for example, for our tea to remove the tea leaves in your tea. So that's a sieve. So sieve-like pattern with hyalinized fibrotic stroma. So remember, most tissues will have a stroma that is mainly connective tissue, and then we have the parenchyma, which is the functional part. And then you are likely to see it's likely to invade perineulum, that is around the nerves, and that is why you develop the nerve pain. So it tends to invade the perineulum region and even the nerve. And that is what causes the extreme pain, because it is invading into the nerves. So this one is seen most often in the submandibular. So this one affects mostly the submandibular and sublingual gland, and it's also in the minor. It can also affect those minor salivary glands. Those are the smaller ones. And most of the time it is locally invasive. That is basically around where it is, it tends to invade into just the surrounding tissues, immediate surrounding tissues. And is prone and also prone to recurrence following surgical excision. So most tumors, when you find them early on, you are able to excise. That is basically trying to cut it out in totality. But sometimes this particular tumor tend to recur after surgical excision. So you remove today, then maybe 3 months later, you realize the tumor again is recurring. And of course, it spread. Like we talked last time about how cancers and so on are spread. So mostly it tends to spread to regional nodes. That is the lymph nodes that are near around there, maybe around the neck, head and neck region. So it frequently tend to spread to the regional lymph node. And also it can spread widely. Yeah. So wide local spread around that area is common. The rate of growth is often slow. So it tends to grow very slowly. So if you are to take the history, somebody will tell you it has been growing over a long time. So maybe somebody would have had that tumor for the last maybe 5, 6 years or even more, because it's usually it will be slow growing.